Welcome. This week we will cover hemostasis and blood banking. Sam, a 22-year-old female, history of prolonged heavy periods. She occasionally has spotting in between periods. This is getting worse after birth of the first child 2 years ago. Frequently she's been having excess bleeding since childhood. So it is a case of excess bleeding. Further history: often gums bleed when brushing, had frequent nosebleeds. On examination, you may find few petechiae or purpura on the skin or oral cavity. To exclude other causes, she has no shortness of breath, recent fever, infections, weight loss for malignancy, no history of renal or liver disease. Note that they also cause bleeding tendency, and many drugs can cause. Family history: mother has easy bruising, hysterectomy for menorrhagia. So there is a family history of bleeding tendency. She has no hepatosplenomegaly or lymphadenopathy to exclude hematological malignancy, lymphomas, leukemias. Now, laboratory: WBC normal, platelets normal. But the coagulation studies, PT is normal. That means the extrinsic pathway is normal. But PTT, the intrinsic pathway, is prolonged. Bleeding time is slightly more, up to 10 minutes is normal, so 13 minutes, and 1 millibrand factor is less. Okay, most of the factors are expressed as 100%, so normal is 100, usually less than 30 it is deficiency causing bleeding, most of the factors. Okay, when do we do bleeding evaluation? Asymptomatic patients undergoing a surgical procedure where there is personal or family history of bleeding is a concern, or any patient with a concern for increased bleeding, easy bruising, delayed wound healing. Patients with the previous bleeding disorder diagnosed, detailed history is important. Family history, drugs, infections, other disorders. Laboratory tests are complete blood count, platelet count. The commonest cause of bleeding clinically is platelets, so platelet count is a must. Then the coagulation studies, PTT and PT. In special conditions, fibrinogen and thrombin time. Other factor assays, platelet function studies, bone marrow examinations only on special indications. So I would expect you to know very much detailed about CBC, platelet count, PTT and PT. Now in this patient there is a suspicion of von Willebrand disease. Unlike hemophilia, even females are affected because it is an autosomal dominant disorder, unlike hemophilia, which is X-linked. Von Willebrand disease is a combined platelet function disorder due to lack of von Willebrand factor and factor 8 deficiency, because von Willebrand factor carries factor 8 and protects it. So investigations: von Willebrand factor antigen, ristocetin cofactor assay, and that is a platelet function study, and then factor 8 levels. So these are the specific tests for von Willebrand disease. Von Willebrand disease is the second common after hemophilia congenital bleeding disorders. In normal hemostasis, the function of endothelium which prevents coagulation, so normally anticoagulant mechanism is stronger to keep the blood in liquid motion. Any injury to the blood vessel, endothelium, entry of tissue factor into the blood vessel starts the hemostatic mechanisms. The three major mechanisms: blood vessel, platelets and coagulation. The platelet aggregation leads to platelet activation. Coagulation goes through two mechanisms: the tissue factor pathway due to blood vessel damage, and exposure to surface alterations leads to intrinsic pathway. So extrinsic pathway factor 7 only, intrinsic pathway 12, 8 and 9. Ultimately through common pathway they lead to formation of fibrin from fibrinogen, and which forms a temporary clot following the injury. Okay, and that stimulates anticoagulant mechanism from the thrombin, which blocks further activation of coagulation and platelet activation, and then the formed clot breaks down through fibrinolysis to produce fibrin degradation products. So normal hemostasis. Disorders are on the same lines, that is disorder of blood vessel, disorders of platelets, and disorders of coagulation, and in addition disorders of thrombophilia and fibrinolysis. Okay, just a brief summary. Read the normal physiology, extrinsic, intrinsic, and common pathway and their relations. Okay, I have put additional case. Mr. RG, a 30-year-old male, referred by a local dentist. Bleeding is not stopping 3 days after tooth extraction for caries. In the history, he had high fever, muscle pain, back pain, joint pains 2 weeks back. On examination, there are multiple petechiae and purpura over his chest and upper extremities. So here I am trying to give an indication of a viral fever with the petechiae purpura. No other significant medical conditions. Investigations, I have given both CBC and coagulation studies. So please discuss in your home group, interpret and discuss laboratory results. What are the normal hemostatic mechanisms? What could be the cause of uncontrolled bleeding in Mr. RG? And how would you manage this patient? Another case, young pregnant woman presents to ER with a severe pain, swelling of her left leg, has returned from a long flight, had sudden sharp chest pain while collecting her luggage, did not diminish when she rested, but later it improved. She is on pain medication for her chronic rheumatoid arthritis. A clue. She is not a known diabetic or hypertensive, no bleeding tendency. On examination, her left leg is slightly swollen, red and tender. Okay. Again, I have given both the CBC and the coagulation studies. Think about the pathogenesis of our problems. What is the most likely diagnosis? Interpret the laboratory results. What is INR here? Is it normal, abnormal? Discuss the normal thrombolytic and anticoagulant mechanisms. What could be the cause of her swollen leg and what is the cause of her chest pain? And briefly, how would you manage this patient? Okay. So what are the clinical features of bleeding disorders? Superficial bleedings are usually due to blood vessel, rarely, and platelet disorder commonly. Okay. Causes of superficial, visible bleedings like petechiae, purpura, ecchymosis. Deeper bleeds are usually due to coagulation disorders, hematomas, joint bleeds, and they are more common with congenital disorders. So superficial bleeding and deep bleeding. Note that when it is severe, there is no distinction. Even a platelet disorder can give rise to deep hematoma, and a severe coagulation deficiency can give rise to superficial bleeding as well. Now, the conditions you should be concentrating or reading about in this week: the blood vessel disorders, hereditary hemorrhagic telangiectasia, but the more common clinically is simple easy bruising or senile purpura, old age. Drugs, steroids, vitamin C deficiency, viral infections, dengue fever, petechiae purpura, bleeding due to blood vessel damage. Platelet disorders, hereditary is rare. Just note that there are few names, but more common is acquired due to drugs like aspirin, or immune, more common, autoimmune thrombocytopenic purpura, ITP. And viral infections can also damage platelets as well as endothelium together. And another condition you have to remember is DIC, disseminated intravascular coagulation, wherein platelets are markedly reduced. Coagulation disorders are more common in congenital disorders like hemophilia, von Willebrand's. Acquired deficiencies of vitamin K can give rise to coagulation disorders. Inhibitors are also common. Coagulation antibodies, which cause excess activation in the body, causing thrombophilia, but in the laboratory they delay the PTT time. One condition opposite, that is hypercoagulability, excess coagulation. The condition deep vein thrombosis. and then lupus anticoagulant, autoimmune, drugs, trauma, and stasis of blood are all causes of hypercoagulability. Okay. Now, briefly, we cover blood transfusions, basics of immunohematology in this week, transfusion, blood products and their application, red cell concentrate, fresh frozen plasma, cryoprecipitate, platelets, blood group antigens and antibodies. Mainly read about ABO and RH, pre-transfusion testing, cross-match, major and minor, and briefly transfusion reactions and transfusion transmitted infections. The transfusion reactions mainly allergic, mild, febrile and very severe hemolytic transfusion reactions. Okay, thank you.